Good afternoon, ladies and gentlemen, the viewers across the world. It's really a pleasure to be sharing with you our information and ignorance on what we have been able to do so far in terms of conquering cancer. We all know about cancer being treated so extensively in the West, and we always thought it's a disease of the West, and developing world was essentially about communicable diseases. We know that it's not true. With the lifestyle changing and the patterns of diseases changing, we are getting a huge burden of cancer cases in our part of the world too. We are going to discuss essentially the women's cancers because we want to actually highlight the issue of empowering women, and there's nothing better than giving them joy and freedom from diseases such as cancers of the breast and of the cervix. We have a very eminent panel with us. Some of them are they're extensively involved in the research and working on these cancers. To my right, Dr. Shyam Agarwal. He is an eminent medical oncologist, very well known world over. He's Chief of Oncology Division at Sir Gangaram Hospital, a center that is known for doing extensive work and research, including many ICMR projects. Really delighted to have you, sir. The next is, of course, very well-known radiologist of our city and, of course, of the country, Padma Shri Dr. Harsh Mahajan, who is distinguished in his own way in establishing many centers across the city and across the country, which are pioneered. I mean, they actually are, in many ways, the first amongst the many. He is going to be basically sharing with us the issues relating to imaging, which have a major role to play in women cancer and in cancers in general. And of course, Dr. Mehta is the Chief of Laboratory Division and Pathology at Rajiv Gandhi Cancer Center, which is a very high volume center in Delhi. They deal with a large number of patients of cancer, and yours truly is Dr. Chintamani. I am at Safdarjung Hospital. Now, first of all, why are we discussing this issue? The commonest cancer amongst women in India is cancer of the cervix, often ignored. Most patients present very late. Like most cancers in our country, this is one cancer which really is not treatable as of now. And that's a bit of a shame because it's a preventable disease which offers us an advantage of primary prevention in the form of providing a vaccine, getting a precancerous stage detection and treatment at a primary level. Now, this has got to do with the primary health and secondary health centers in the country and the overall health policy. So we got to do a lot in this direction. There are many screening programs that are running across the country, but they run in bits and pieces. Therefore, they aren't able to produce the kind of effect that we're looking at. And the second commonest cancer amongst women is breast cancer, and in certain metros, it will be the commonest cancer. We attribute that certain rise in the last few years to many factors, but the chief amongst those is the burger cola culture that has come in our country. It is a pattern of lifestyle which is changing, and also for some reason we observed in many studies that were done, including the one that we did, that there are two peaks of breast cancer in our country, unlike what you observe in the West. The first peak is in the 40s and the second is in 60s. And it's that peak in 40s which is actually dangerous. It's got a genetic basis and usually a very aggressive cancer, what we call as triple negative breast cancer. Now, this cancer has a very aggressive course, and obviously it occurs at an age when the woman is still in her reproductive age group. She's contributing to the society and primarily to the family. So it has a huge impact on not only her psyche, but of the family as a whole. And when we talk about a woman, you educate one woman, you empower one woman, and you'll empower the whole family. And that's how you should be building your society, and that should be our dictum. Now, I would start by requesting Dr. Shyam Agarwal to throw some light on where do we stand today in terms of both cancer breast and cancer cervix, which incidentally happen to occur around the same age group, although 30s for cervix and 40s for breast cancer. That's what we look at when we talk about screening. And both these cancers are related to the reproductive pattern in women. While we know that multiple pregnancies, early pregnancy, and breastfeeding actually protect a woman against breast cancer, the same factors predispose a woman to cancer cervix. So there's a bit of a paradox, although it occurs around the same age group. So Dr. Shyam, would you like to throw some light on that?
So as Dr. Chintamani has pointed out, so if you take both these cancers in women, they'll constitute around 50 to 60% of all the cancers. And the other thing which is common in these two cancers is that you can detect them early if you were to go for screening programs at regular intervals, say beyond the age of 35, 40 years. So that's a very important issue to be highlighted amongst normal women population, that they must adhere to an annual or at least once in 2 years checkups which involve pap smear, breast self-examination and mammograms, so as to detect them early. As we all are aware that if you can detect these cancers early, you can cure them with fair amount of ease, and not much funds are required, which I think would be a priority, you know, I mean in a country like ours.
That's right.
So these two cancers can be easily detected early, and as you said, cervix cancer is a preventable disease because we have the vaccines available, and in the reproductive age group, if you were to give them 3 shots of the vaccine, you could prevent the cervical cancer, you know, from happening itself. So there are several issues which are now, you know, arising from this. I think I just need to make another statement on breast cancer, which we were discussing. In the Western countries, the incidence of mortality of breast cancer has come down, just because you are able to detect these cancers early, because women adhere to an annual checkup.
Screening is contributing.
Unfortunately, it has not happened in our country. So the people come late. They are scared of going for self-examination and mammograms and examination by the doctor. So we need to highlight that so that we can detect it early and reduce the mortality. Once you have stage 3, 4 breast cancer or cervical cancer, you are looking at, you know, prolonging their lives, you are looking at giving them chemo, hormonal therapy, etc., etc.
And it isn't cost effective, right?
Exactly, exactly. So
the cost that you save in not doing screening, you lose in getting them late. And as you very rightly pointed out, most of the times they are coming late, and we are actually burdened by a disease which is totally different from what you observe in the West. Okay. Now, any thoughts on, I mean, I'll just take Dr. Mahajan's view on screening essentially. Any thoughts on screening? Where do we stand today? Is it, because there are many studies to suggest that screening in breast cancer is not the best thing to do, and there are studies to the contrary too. So would you like to throw some light?
It's as you say, a controversial area. Some controversy which has come in the last few years.
That's right.
But there's data available which shows that it saves lives. There was some controversy created by a US task force which actually looked at the same data.
That's right.
And then they came back, but saying that instead of starting at 40 years, we start the screening program at 50 years. You have to realize in the US, the insurance companies pay for that screening.
Absolutely.
It's not going out of patient's pocket. So there is a group which would benefit in case the mandatory screening program is pushed back from 40 years to 50 years. And in the US, currently they practice from 40 years on an annual basis.
Absolutely.
X-ray mammography. This US task force actually said do it once in 3 years. And there was a lot of controversy. The Radiology Society, the Oncology Society,
yes,
they didn't agree to the task force recommendations. And even 4 years down the line, this came somewhere, if I remember correctly, in 2010 or 11.
It came in 2011 actually, and that's related to a Canadian study.
Absolutely.
Where they found that it may not be so useful.
Yeah.
It made a point, I'm sorry I'm interrupting you there, but we all agree that, that screening, if nothing else, has brought down the mortality. It's an established, documented
evidence. Just to take one more point, they said that between 40 and 50 years of age, it saves lives.
That's right.
But it is not worth the money spent.
Absolutely.
So, I mean, that was quite a startling statement to make. And so, despite these recommendations, in the US, the insurance companies continue to fund this. In our country, whereas Dr. Agarwal has pointed out, we get breast cancer earlier. And even in the 30s,
yes,
we would be doing a disservice if we were to say that screening should start at 50. I think 40 is the right age.
Dr. Mahajan,
yes,
it's our own paper that I would draw your attention to kindly. we found that in 30s we get cancer more often than we get in 60s. It's a coincidence that we were studying BRCA1 mutation in this group for a change, and we observed that this is one cancer which was, that time there was no talk about triple negative.
Absolutely.
And here screening, as you very rightly mentioned, as a radiologist, what do you suggest should be there for our strategy to screening vis-a-vis the West, because our cancers are presenting early?
See, 40 I think is still the right age, because the young breast is more, prone to getting some kind of damage from the radiation. Of course, one has to realize that X-ray radiation for the mammogram has reduced over time. Now with the full field digital mammograms that are available, the radiation dose is substantially 20 to 30% lesser than what it used to be. But I personally feel, as yet, as you know, we have no screening program in this country.
Yes, yes.
But if one were to choose to enter into screening of one's own will, I think we have to subdivide women at large into those at average risk for developing breast cancer and those at high risk for developing breast cancer. And accordingly, those in the high risk, one could start even earlier. You could start with ultrasound or even with MR mammography, which is quite widely available in our country, so as not to subject these young ladies to radiation. And those at average risk start at 40 years, and my personal belief is that we should do once in 2 years for those at average risk rather than an annual mammogram. In England, as you know,
yes.
NHS does it starting at 50 years and
yes.
once in 3 years, but then they have their own constraints of availability of machines.
They're also running out of funds very quickly. And Dr. Sham mentioned a very valid point, that it's more about bankruptcy of thoughts than actually the money. Because when you look at it, you end up spending more money at providing care with multimodality therapy coming in. In the West, they are treating images, and here we are treating lumps. So there's a big difference between what you're treating there and what you're treating here.
Very true. And even if we look at cost-benefit ratio,
yes.
It's not just the cost of treatment, but also the overall burden
yes.
on society of the morbidity and mortality. I mean, that's something which probably one may not even be able to calculate.
And the other thing that it does is it gives a poor image of cancer per se, because almost everyone who comes with cancer dies very quickly. Yes, Sham.
Yeah, I think as MR mammography, I think as Dr. Mahajan said, so I think it needs to be pointed out that people who have a strong family history of breast or ovarian cancer, so they need to start 1 decade earlier than the incident case.
And for the benefit of viewers, the strong family history essentially means that the first degree relative, it could be your immediate sibling or cousin, who has got breast cancer or ovarian cancer, cancer pancreas, let's look at it, any cancer, which has happened at an early age, because the age is important, because the genetic or the hereditary cancer is usually at an earlier age. And as rightly pointed out, these patients are very vulnerable, these individuals, are vulnerable to developing it. But the idea is not to scare the hell out of them that they're going to get cancer tomorrow. But at the same time, it is better to be aware rather than to be in dark. And actually today, cancer is like any other disease, cancer breast especially in the West. It's like any other disease, and people live their full lifetime. Now, when we look at cancer cervix and cancer breast together, now I'll just take you away from imaging. The recommended model for developing countries is slightly different. And in many studies that were conducted across the continent, it has been found that unless you bring down the lump size to less than 2 centimeters, this screening thing is not going to really help. Except the opportunistic screening, which Dr. Mahajan was referring to, where an individual chooses to go and get it done automatically, because obviously you've got no reason not to get it done if you're aware and if you have a center close by, and actually if you can afford it. But mass screening and a journal screening program doesn't exist in our country, unfortunately, which would definitely contribute to bringing down the size of the lumps. And actually presently the recommendation is, rather than self-breast examination, clinical breast examination and awareness. In the process, this can be taught even to midwives. In one study that was done at Tata, they found out that midwives, and also at Trivandrum, they found out that midwives can be taught into detecting these lumps. And along with that, they could do the VIA, which is visual inspection for cancer of the cervix, which is a very simple test that is done using iodine. And they actually can report these patients immediately, and sometimes if you can detect a precancer, they can use some sort of cryotherapy. I thought I'll give this background before we get into the MR mammographies and other things. But to make it simple, MR is a rich man's ultrasound, and ultrasound is a poor man's MRI. Dr. Mahajan did not like it. But by and large, the indications, as you rightly mentioned, ultrasound is more useful at a younger age group because the breast is denser, and also we don't want to expose our ladies to radiations. Now, the breast especially and also the cervix both end up having a diagnosis with a pathologist who actually is the final diagnosis. Like you all have read the book by Arthur Haley, The Final Diagnosis. Pearson gives the last word. So I'm down to Dr. Mehta now regarding how often does he get to do the core-needle biopsies as a part of triple assessment in breast cancer, and the DNA or other tests or the smears for cancer cervix. Dr. Mehta, please.
So as far as the breast is concerned, once a lump has been identified, it is absolutely essential that this lump must be examined microscopically. The microscopic examination come in the form of either a fine needle aspiration cytology. A fine needle is a 21 gauge needle which is inserted into the lump, either under some sort of an imaging, or if the lump is palpable blindly, and a small amount of tissue juice is taken out, and then this tissue juice is examined after staining for presence of malignant cells or tumor cells. Actually, only 25% of the lumps are malignant, 75% are benign, so one should not get scared that this procedure is being done. However, this is necessary to establish a diagnosis. Now, the FNAC is actually the fine needle aspiration cytology. It's a wonderful process. It can be done in the office. The patient can go back to his or her place, to her place of work in an hour or two. But the disadvantage of FNAC is that it has the accuracy levels which are not considered acceptable in most part of the Western world. And also it cannot distinguish between an invasive cancer and a cancer which is still confined into the milk ducts. So the treatment that Dr. Chintamani and Dr. Shyam Agarwal will plan for this patient, if the tumor is restricted to the milk ducts or if it has gone out of the milk duct, will be different, and this distinction cannot be made by the cytological examination. And therefore, more and more people today are actually moving to taking bits of tissue out by using a 14 gauge needle, which is called needle core biopsy. 4 to 6 cores are taken out, and the advantage of taking these 4 to 6 cores is that the accuracy of the diagnosis is enhanced. The sensitivity is about 80%, so 80% of the cases you will get the tumor, and more importantly, you can, especially if this cancer is in the advanced stages where you have to use upfront the chemotherapy and the tumor subsequently will not be available for examination, this tissue can be used for doing what is known as the biomarker studies, where we look out for estrogen receptor, progesterone receptors, and HER2 receptors. And the treatment will be largely decided by the nature of these receptors. So that will be the initial diagnostic plan. For if this is an early breast cancer and the surgery has been performed, there will be a resection specimen which will be available, and that resection specimen will then be used to find out the extent of the disease, which we call as a staging procedure. And this staging is very, very essential. Probably this is the most important criteria in determining the prognosis. Prognosis means as to how this patient will perform in absence of a treatment. As far as the cervix is concerned, as you said, that basically primarily we only have opportunistic screening, where a patient will come and a smear is taken from the cervix. The smear is taken using a spatula or something like an ice cream spoon that we have, the wooden spoon, and this material is then spread on a glass slide, and it is stained and examined for presence of any abnormality which is suggestive of a precancer. And the advantage of identifying these precancer is that the treatment which needs to be given is minimal, with absolute, saving virtually from an advanced cancer. Now, while we are actually examining these smear, there are certain gray zones which we call as atypia of undetermined significance. And here one is not sure whether one shall just follow up or what to do, and then one can actually look for the virus or the signatures of the virus which is causing these changes to happen, and which is called human papilloma virus, HPV. And we try and identify this HPV by looking at their DNA signatures. Now, the disadvantage of looking at the HPV signature is that many women can have HPV signatures which will in 1 to 2 years time wane off by themselves. Yes. So you will probably be picking up too many individuals for further evaluation. So in most places the HPV DNA is only limited to looking for the cases of atypia of undetermined significance, but otherwise in many countries the pap smear or the cervical smear examination with HPV DNA has been recommended, and this in turn leads to reduced frequency of examination. Absolutely. So while if you were to do it 2 years, now you can actually, if both are negative, you can do it after 3 years.
Brilliant. Actually, what you just understood was the gist of whatever is done at the moment a patient is sent for final diagnosis. And as you rightly mentioned, fine needle aspiration cytology, which you commonly find being done, is certainly not the gold standard. The gold standard is core needle biopsy. And contrary to what was earlier believed, it's not an expensive needle, that it's not going to cost so much these days, and it isn't a painful procedure. The advantages here highlighted would actually give the correct diagnosis in most cases. The false negative rates, that is, missing out, is less, and at the same time you all know all about the tumor, its grade, its invasiveness, the marker status, as you rightly mentioned, to put the patient on some kind of a therapy. Having said that, a lot of these patients would require some kind of a metastatic workup at some point of time. About cervix, I was just trying to simplify all the complicated terms that may not be very clear to many people. Visual inspection is a method where you throw iodine at the cervix, and the cancer cells would not be able to, they don't have glycogen, so they won't be able to clear it off, and they will stain brown, and that's one area where you can take a biopsy from, and you can actually cauterize if there is a precancer. And rightly mentioned, the study of HPV, DNA, etc. is not only expensive, although it's a useful method to just take a vaginal swab, which the patient can give herself to the nearest lab and get it done, but it has its own limitations, as very rightly brought out. Now, regarding the further workup in these cases, they would need some kind of a metastatic workup where we rely a lot on imaging. In addition to finding out, I mean, as triple assessment, we basically meant clinical examination, which is a thorough clinical examination by somebody who does it all the time, and imaging, which could be mammography, which is considered to be most sensitive, ultrasound in a younger patient, or a patient who's pregnant, or a patient who's received some kind of a therapy, or with some other associated features where the architecture may not be very good, where Dr. Mahajan would highlight further, and followed by you do MRI as a problem-solving tool, I believe.
It is a problem-solving tool, yeah. And just to highlight that out of probably 100 patients who undergo an X-ray mammogram, maybe 2 would go in for a MR mammography.
I'm sorry I'm interrupting you. I've seen the images coming from your center. They stand out actually, and sometimes you wonder if it's as good as the best that you possibly can get anywhere in the world, having seen it.
Even though I'm
paying a compliment to you while I'm trying to actually answer that part. So why is it that other centers or other people like to get more MRIs done than probably you are recommending, which I agree with you completely?
See, it is only when you have a high index of suspicion, an indeterminate lesion on X-ray and ultrasound, where you're not sure. You know, we have the BIRADS classification. I would not like to go into that, but where you're not sure, and where before actually doing fine needle aspiration or
and imaging is always done before we put in a needle. That's I thought I wanted to highlight.
And you know, so that is one situation where you're not sure. Is it cancer? No, this is not cancer. That is where MRI can be helpful, non-invasively, without actually having to put in that needle, be able to tell you it's not 100%, but you can be reasonably certain. Number two is the situation where you've already diagnosed a malignancy. And today is the age of breast conservation surgery.
I was coming to that.
Yes, where only the lump is taken out. And in the previous ages, or where it's extensive and the entire breast tissue is taken out, it's a separate matter. But where you're trying to conserve the breast, there you want to know whether there's more than one malignant lesion in the same breast.
Your wonderful point you made, and Dr. Mahajan, I must compliment you on that, but MRI has been shown to reduce the conservation rates because it picks up too many artifacts.
Yes.
And as a surgeon, we generally look at it as a problem-causing tool rather than problem-solving tool.
See, that may be true,
Yes.
but you do not want to end up with operating and doing a conservative surgery on a patient and then realizing there were two more cancers in the breast.
Your point is taken.
And I think the experience of the person reading the scan, and at times you do need to do more than one.
And when you combine the two, Dr. Mahajan, I was trying to get the middle path, or Buddha as they call it, MR memo.
Yes.
What difference does it make to this confusion?
See, when you combine MR mammo with the FNAC, you know, of course you would not be doing 10 FNACs from 10 different lesions, but now over time we've recognized, and especially in those who have dense breast, fibrocystic disease, you do get non-specific areas of enhancement, but as has been shown in literature, the standout lesion, the lesion which is actually most malignant, the lesion which is going to cause further damage to the patient, that is something which always stands out. And the others tend to suppress over time with chemotherapeutic agents or hormonal agents that are given later. So I think in this age of conservative breast surgery, even though you're right, MR mammography does pick up, it's very sensitive, it does pick up non-cancerous lesions, but we have to live with that, at least till such time that some more technology comes.
Perfect. You made a point. Dr. Shyam, would you like to throw some light on the necessary or unnecessary PET scans that patients walk in with?
Sure. So when we are faced with a person or a lady who has a breast lump which is proven to be malignant on pathology, so we need to take a call what to do next. So we need to do the staging tests. So what is recommended is to do simple things such as including, as you said, physical examination, followed by a blood profile which includes hemogram, kidney, liver function tests and coagulation profile, a simple chest x-ray, an ultrasound of the abdomen and a bone scan. So these are the three tests which we must carry out in an individual to stage a person's disease. What we are seeing today is the PET CT scans being done, just like that. Maybe patients are asking for it, but I for one dissuade my patients unless they're extremely keen to go for a PET CT scan in the initial workup of a suspected stage 1 or 2 breast cancer.
Agree with you.
So there's absolutely no role of doing,
For that matter, even in locally advanced breast cancer, PET CT, except if you're putting the patient on neoadjuvant chemotherapy and you're insisting on PET RACIST criteria to assess the response for the biological activity also, by and large, it's not a standard of care. Essentially, it is for remnant or recurrent disease that you do that, but it's not a standard of care, and as Dr. Shyam rightly pointed out, many patients just walk in with a PET scan, and the trouble with PET scan in our part of the world is that even tuberculous lesions pick it up, and you get a disease which you probably may not be metastatic. You have a node in the mediastinum and you start wondering as to what to do next. Very much like the MRI picking up an artifact and you worrying or you're scared because you may not do a conservation in that case. There is a flip side to everything, but there's an advantage with PET, which I would like to ask Dr. Mahajan. What would be your recommendation for a patient to get a PET scan done? The recommendation is otherwise, what we just discussed it in our scenario.
See, even in our scenario, as in the West, it is not every patient who needs a PET scan. Where you have locally advanced breast disease, where already you see that there are lymph nodes which are enlarged, and you suspect that there may be distant metastasis.
By and large, not a routine. Not a routine. We are dealing with a problem that is pertaining to our people, our patients, and we need Indian solutions to Indian problems. So there's no point having an American solution to a problem which is very Indian. our patients present late. Most of our country still lives in villages. And let's not just talk about those fancy investigations which attract patients, especially in the metros. Now, what do you think are the major problems, Dr. Shyam? Because I understand we don't have a screening program and government doesn't look too inclined to have it, not only the cost being a factor, and as I rightly mentioned, they are advanced. I mean, there need to be awareness amongst the patients too.
Just if I could interject, you know, as regards screening program for mammography, I mean, even if we had the money, where are the people who would read the scans? You know, you'd be surprised. I know from Malaysia, where they have a screening program, and there are lakhs of scans which have been done and have not been read. So even that end of the...
I was looking at that from, I mean, if you were a part of the last program, we're looking at teleconferencing with somebody like you in Delhi and having centers spread all over the country to cover up the backwaters of this country too.
So even the teleradiology, even if it's available, we don't have trained people, the numbers that would be needed if we were to have a screening program in the country.
We have a problem in terms of manpower and also the money, which is huge. And I don't think health gets that kind of a priority in our setup in any case.
Exactly. That's the most important point.
People
are not willing to go ahead and get themselves
They're finding
examined.
it hard to understand that communicable diseases are not the only killers in this country.
In fact, in your hospital or in any hospital, the one department where you would see that there's hardly anyone there, generally the hospitals are crowded, is the X-ray mammography department.
We won't get to the grey zones. I'm therefore asking Dr. Shyam your views on where do we stand and where do we go from here, so that we can have a quick wind up of the future. And we actually, you know, it's in any case it's a race that we must win. And we haven't done too badly. The mortality has dropped, but the trouble is the numbers also increase. So I mean, vis-a-vis the numbers, we don't do that well. So it's not apparent, but we are making. I mean, we are getting. I'll quote from a public hospital. Our conservation rates have gone up from maybe about 15% to about 35% now in breast, which is a credit to everybody who. I mean, the patients themselves. So they are seeking. They are hungry. So your views on
right. So as a medical oncologist, yes, you know, I like to make a few sort of statements here. So we have made tremendous progress, yes, in terms, because the load is of metastatic or advanced breast cancer which we are facing, because if you look at the proportion of patients who are coming in advanced stages is to the tune of 75%, and only 25% would be in the early stage in the curable zone.
I understand.
So, you know, we have made progress in terms of, you know, developing newer hormonal therapies. So at the moment, we at least have 6 to 7 lines of hormonal drugs which could be used in a sequential fashion to prolong the life of a given individual who is got a ER/PR positive breast cancer, number one. Number two, in terms of cancer chemotherapy, the drugs have become simpler, the treatment has become easier in the daycare on a weekly basis, and like hormonal therapies, we have at least 10 lines of therapy for a breast cancer patient. The third area where we have made progress is the HER2/neu gene. So we have 4 lines of treatment today available worldwide for attacking the HER2/neu gene breast cancer. So, you know, what we say when a patient comes to us with metastatic or advanced breast cancer, that there are going to be several chapters in the life of a given individual. So which will be governed by the response to one hormone or a one chemotherapeutic drug or a one anti-HER2/neu agent. So a person who was earlier living for 2, 3, 4 years is now going on to live for 7, 8, 10 years with the metastatic disease.
All credit to the medical oncologist. I'll tell you why. Because Halsted, Fisher, we haven't moved beyond that. Right. What is added to conservation is chemotherapy in a big way, and also the radiotherapy, where we actually have excelled. And the credit goes to all, and actually medical oncology has progressed, as you rightly mentioned. A couple of questions which you covered in your statement, so I wouldn't take them up. Thank you very much for that. And the other question was basically for Dr. Mahajan. Is it, they wanted to know more about elastography. Is it better than mammography? The same old question. Do you think it's better?
No, elastography is a part of routine ultrasound examination. It is claimed,
I could have said it, but I wanted it to come out of your mouth.
It is claimed that it improves the overall lesion characterization, differentiation between benign and malignant lesions.
So you don't think it is more specific than mammography?
It adds some specificity, but is not absolute.
In
by any
isolation,
stretch.
in isolation,
No, it's not as if
really.
you are not going to do a biopsy.
The other question was, is breast cancer in younger women? Thank you. The breast cancer in younger women more aggressive? I mentioned already, it is. And actually the concept in oncology now is that you have a cancer when you are in utero, and the time it takes to show up is the aggressiveness of the cancer. So if it appears early, it clearly is a faster growing cancer. If it appears in a woman at 80 versus a woman at 30, the one in 80 is a pretty good cancer. So that you can answer very straight away. Now, what percentage of patients are HER2 positive in your observation? That's a question, so I thought I'll pass it on. I'll take the other question meanwhile as they fix up the mic, which is relating to, is surgery the only solution to breast cancer? Or I was very obviously saying that surgery is not the only solution. In fact, I said medical oncology scored over surgery. If I look at my surgery today vis-a-vis what I did 20 years ago, it has changed primarily on account of neoadjuvant chemotherapy, which can make a tumor shrink greatly, and I can get a clear margin, and we are doing conservation even in a locally advanced cancer, which is a big achievement. So it's a treatable and within cover the curable cancer. Now we can get back to the HER2 now. Yeah. Now we'll take the other one, there's no problem, we'll get back to you. FNAC, well, any imaging has to precede any invasive procedure. Any non-invasive procedure has to precede any invasive procedure. That's a basic protocol in science, in surgery, and in medicine and in radiology elsewhere. Because if you put in a needle, you can produce an artifact which can give a false imaging impression. Am I right, Dr. Mahajan? I
Well, sir,
your territory.
no. That's perfectly right. But there are situations, even after a biopsy has been done, because it's been done elsewhere.
What would you prefer?
Comes to you. We would prefer doing it before.
Yes, you would need a virgin breast to do it on.
That would be the best.
Yes, that's the best.
Possible. Yeah.
Now, so that part covered. By and large, regarding the how many women with breast cancer have positive HER2 new? You can.
So we have HER2 positive cancer in two categories: those with ER positive, PR positive cancers, and those which are ER/PR negative but HER2 positive. In our own center, we have studied about 1,000 cases. About 9% of these women are positive for HER2 with ER/PR, and about 15.5% are positive for HER2 without ER/PR. So probably in Indian context, where as we all say that the cancers occur
ER negative, PR negative, and HER2, all three are negative, which is bad news actually, because it's supposed to be a bad cancer. But Dr. Sham likes these patients because of a good response to chemotherapy, what we call as triple paradox. At the end of the day, they don't do that well, although they respond to chemotherapy that much better. It's an aggressive cancer which is seen mostly in African Americans. It's observed in India. Our data was 33% were triple negative in our scenario, and they do very poorly, and they're very aggressive cancer. They come early, and they're younger age group, that's when they come. One question which would be overlapping is about FNAC. Is it reliable in today's world with breast cancer being heterogeneous disease? Like we mentioned, FNA has its limitations of being with false negatives, and core needle biopsy is the gold standard. But in a country like India, FNAC is still the first investigation that most centers do. However, what is recommended is a core needle biopsy. Am I right, sir? How about the ultrasound of the axilla and assessing axilla based on imaging? Because we prefer a node which is visible is a positive node, unless put otherwise.
See, if it has a fatty hilum, has a normal morphology on ultrasound, then we can be reasonably certain that this is not a malignant node. But then, any large node, to be absolutely certain, whether on CT or MR or PET-CT, to be sure, you have to do an FNAC.
Okay.
Or take the node out.
Can I ask a question, Ram?
Please.
So, would it be a correct statement to say that if somebody has 1 to 2 centimeter solid lesion in the breast,
what you're coming to.
So would you just leave that at a core biopsy, or should that be taken out and excision biopsy should be done?
Can I answer that on their behalf?
Yeah, because you are the surgeon.
A palpable node is a positive node, unless put otherwise. I don't care if FNAC is negative, because it won't change my management. I'm sorry. The standard of care I'm familiar with the Aberdeen working, where it was routine to core all nodes in the axilla. But as you rightly mentioned, a highly suspicious node on ultrasound, where you find that shape has become more ovoid, and hilum is, as he said, fatty hilum has disappeared. There's a central area of necrosis, and there is that halo sign where you lose all the capsule. You would have no reason to even put in a needle, you're sure about it. The only situation where we found it to be useful, and I agree with him, is when you don't have a lesion in the breast. You're dealing with an axillary node with unknown primary. So that's where it came handy. Otherwise, the palpable node is positive node as far as we are concerned.
Case of a unknown primary in the axilla.
In the breast, yes.
In the axilla, you haven't found the primary in the breast. I think this is one situation where you will probably want the node out, because here then you can do ERPR, HER2, and you can probably look for any other primary by doing the relevant investigations. So in this situation, I will personally feel that FNAC...
You would want to know, are you happy with the core needle? If you give a tissue?
But you know, like here, probably you will do a workup to figure out whether it's actually...
The algorithm is that you do an FNA or a core needle biopsy, and I was trying to actually agree with you on that, because in that situation, core needle biopsy would give you the tissue which you need to actually comment on what is the immunohistochemistry and everything about the primary which can help you.
Exactly.
Now, I mean, if I would take 1 minute each from each of our very eminent panelists. It's not very often that you'll get to find them all sitting together here, very busy people. So 1 minute as to where do we stand, what do you see should be done, should be the Indian solution to Indian problems?
No, I like to make a few comments from this discussion. One is that the role of PET-CT. We've seen patients who, as you said, they come with nodes in the axilla or in the mediastinum, which changes the stage of a breast cancer in the initial workup. And we've seen patients of stage 1 or 2 being diagnosed as stage 3 or 4.
I agree with you.
So I think PET-CT should not be overdone. And if you have a node, kindly be very careful.
Don't get it done on your own, firstly.
Yeah.
Secondly, if your GP tells you to get a PET scan done, please see a specialist. PET is not something that you should do as a PET. Never bet for PET. There is an editorial on that. So I agree with you on that.
The second point I'd like to make is that in a patient's treatment for breast cancer, it's a multidisciplinary
It's a multimodality therapy, so we all contribute, all of them. It can never be surgery. And it has to be, as he rightly mentioned, chemotherapy, that is you can poison it, surgery you can cut it, radiotherapy that you can burn it, and at the end of it you have hormone therapy. It's one tumor which responds to hormones because its breast is a hormone dependent organ, and this cancer is also hormone dependent. And if it is hormone positive, that is ER positive, it is good news for the patient, because you can put the patient on tamoxifen, which is a very cheap and easily available drug, not very cheap, but I would say not very expensive. And especially the 5 years versus 10 years controversy is there. Nowadays it's recommended that you give it for 10 years, and it's been found to be beneficial. But 5 years of tamoxifen as a routine in those who are positive. Those who are ERPR negative, they receive no hormone therapy. In them you have to give chemotherapy. And by and large, radiotherapy would also be a part of it. So chemotherapy, surgery, radiotherapy, hormone therapy, and many other therapies are emerging wherein you can actually treat cancer of the breast effectively, and you can actually win over breast cancer because it is a curable disease if detected early. A word about cancer cervix, because most people shy away from discussing about it. It is at the same age group. Therefore, when a patient is coming or a lady is thinking about breast examination, must get a cervix also examined. It's not a very difficult test to do. Easily available visual inspection test or HPV test, the DNA test, and HPV vaccine in the reproductive age group can actually save you and protect you from cancer cervix, which is not so rare in our country. Unfortunately, still 40 to 50% present in a very advanced age. And the trouble is, it takes a little longer time than from the pre-cancer to cancer stage and inside to becoming invasive. So there is a long lag phase where you can actually miss out the disease. Dr. Sham, you wanted to make a point.
Right. So I think the controversy on the duration of hormonal therapy has virtually been put to rest. So currently for premenopausal women, you should give them 10 years of tamoxifen.
Yes.
Based on the Atlas trial.
I was trying to, yes, certainly, yes. Atlas trial has proven it.
Yeah.
And aromatase inhibitors along with tamoxifen is what, I mean, essentially aromatase inhibitors are for the postmenopausal women and tamoxifen for the premenopausal. Yes.
Taken tamoxifen for 5 years and become postmenopausal, switch to aromatase inhibitor for another 5 years.
That's right.
So hormonal therapy should be for 10 years for the...
10 years is what is considered beneficial over 5 years. So ask for 10 years when somebody is offering you for 5 years. Now, your quick
I would say, Professor Chintamani, that education and awareness,
Absolutely.
that's the key. You have to look after your body yourself. No one else is going to do it. Don't be scared. And even in this age of technology, breast self-examination still is a good thing. Clinical examination, as you said, which can be taught even in the periphery to midwives, is helpful. And then you come to technology, and again, those at higher risk have to be more aware, because their chance of developing cancer...
More aware rather than be more scared.
Yes.
Absolutely.
Because if you're aware, you don't need to be scared.
That's
because
right.
you can take care of yourself, you can get early diagnosis. And as has been said, early diagnosis means cure.
When?
It's not that you're controlling it, you're actually eradicating it. And X-ray examination for the breast, X-ray mammography, widely available in our country, very less used. Ultrasound, especially for dense breasts, for young breasts, patients who are younger, is very helpful, also helpful for guiding for biopsies. And then following that, where needed, very judicious use of MRI and PET scan, and there is also scintigraphy, which can be used,
Yes.
which it can give you more lesion characterization, but I don't want to complicate issues. But the bottom line is screening helps.
How wonderfully summed up. Awareness, screening, lack of fear, and you can conquer it. You should help your physician conquer it, because you're a party to this fight, and you can't let the physician fight alone or in isolation. A quick one word on that. We have some questions which clearly shows that there's a lot of interest that is being generated thanks to what you've been contributing, and there are some questions that have already been covered.
Simply covered it. Basically, it's education, education, and education. And after that, I think access to the primary health care, and the primary health care worker should be trained to carry out a good clinical breast examination. And then I think we have to allocate more funds to healthcare so that we can reach second tier and third tier cities. The metros are very well covered. The problem is that these people have to travel to the metros, and the logistics become a problem. So we have to spread the availability of the medical care to tier 2 and tier 3 cities, and I think that will happen probably in partnership between the private sector, and the government will have to allocate more funds.
Yes.
Because with 1.5% of GDP allocated to healthcare on a very narrow GDP base compared to 15% in advanced countries, I think we may want to do more, but the resource is actually really a crunch.
Absolutely. How nicely put. Public-private partnership, and don't expect government to do for you everything. It doesn't happen that way. It'll have to be a combination of all the factors. At the end of the day, where we reach is decided by how do you start and when do you start. There are a few questions which have partly been covered. I'll take them out. One was on PET, which was very eloquently answered by Dr. Shyam Agarwal. Now, there is a question regarding surgery, radical mastectomy with axillary clearance, which actually is radical mastectomy itself, versus breast conservation is the patient selection criteria. Well, first of all, please do understand, it is not less optimal or suboptimal surgery. It's a surgery which is all that you need. We're probably doing more than we should have been doing in those cases. Early breast cancer, breast conservation is a standard of care, which means stage 1, where you basically have a disease, I'll put it in simple terms, confined to the breast and maybe to the axilla, but the nodes are still mobile. If the patient is willing to take those visits to the hospital on regular basis. But what we miss out is, it's the patient who is the key player in this. And you must explain to the patient that breast conservation produces as good results as modified radical mastectomy or mastectomy, but there is a higher local recurrence rates, which is to the tune of 5 to 10% in breast conservation. And that's why, I mean, in spite of radiotherapy being given, the local recurrence rates are higher. But we need to explain to the individual that in spite of that, the overall survival doesn't change. So what actually I'm saying effectively is that you won't be carrying a ticking time bomb inside, which is a regular question by a patient. Then why are you giving me radiotherapy if I don't have anything left? It is to cover up for the rest of the breast, and breast conservation is the standard of care in early breast cancer. So every patient who's willing for it is an early stage cancer. The surgeon knows how to do it, and there are multimodality therapies available. The center has the facility for it. Patient is willing to come for follow-up. Patient doesn't have a contraindication to chemotherapy or radiotherapy for whatever reason, not available, or patient being pregnant or in a situation where she cannot take it. It is a doable option. Coming to the locally advanced breast cancer, it is feasible to give breast conservation therapy after downstaging with the help of Dr. Shyam Agarwal. Neoadjuvant chemotherapy, tumor brought down. It's like getting the demon into a small cage and then getting the clear margin. The bottom line in surgery for cancer is that you get clear margins, which actually means there is no microscopic evidence of disease left behind. But in spite of that, all three modalities would be needed. So any patient who is not fit for that is not fit for conservation. There's a question for Dr. Mahajan. What is the most common site that you observed in your practice for metastasis from breast cancer? I could have answered that, but I thought...
Why don't you go ahead and do it?
No, please.
I mean, we find, of course, the commonest, of course, are the lymph nodes.
The system.
Distant mets, lungs,
Liver and bones.
liver,
Where you
and
get
bone.
it? We can more commonly in the bones.
Yeah.
And
That's why a bone scan is one.
bone scan, that's
test
why
that
is
is,
recommended. All patients with early breast cancer who are symptomatic with bone pains, that's a recommendation of NCCN guidelines. They need bone scan. Otherwise, all LABCs need bone scan and a metastatic workup, which as a standard of care is CT thorax, including the upper abdomen.
Absolutely.
And the lower abdominal for ultrasound and looking at the endometrial thickness. The patient is to be put on some kind of a therapy. There is one question which would be of interest to you, because that's somebody asking, is corneal biopsy superior to FNAC? But you have answered that. That covers up most of the questions that were asked. Now we have a couple of minutes to wind up this discussion, where I thoroughly enjoyed. Actually, as I mentioned in the beginning, I was to learn from these eminent people about what do they think about is the present status of these two cancers and the future. So how do you look at the future, sir?
So I think...
Which is good?
No. I need to make a statement here that should not be scared of the word cancer.
Yes.
If you are detected early, you will be cured. And if you have advanced disease, we have now tools to convert it into a chronic disease like high blood pressure or diabetes. So don't be scared of the word cancer.
Fear out. Information, wisdom gets the fear out. Ignorance brings in the fear. So we know that it's possible to manage it early, curable. Advanced, don't let it get advanced. You should present early. Be aware of your body, as rightly pointed out by Dr. Mahajan. Way ahead.
Just taking it forward, I would say that after you've been treated and hopefully cured of the disease, please do not lie back and ignore the
I'm glad you brought it up. I was coming to follow up in the last part.
And in the follow-up, there are technologies available, and the PET scan. You know, the much reviled PET scan plays a very good role in follow-up to pick up any recurrence or early or any other tumor. I mean, we need to remember that a breast cancer can also
coexist
occur
with
in the other breast
cancer
later or at the same time. So we have technologies available, and you need to be aware of the fact that a cure, even if it's a cure, doesn't reduce your risk of future cancers. As we know, because you were at risk, you still remain at risk.
Absolutely. And I take a leaf out of your chapter, that's education, education, education. So that is the bottom line.
Actually, carcinoma cervix is just a sexually transmitted communicable disease. And therefore, if we can deal with other communicable diseases, we can deal with carcinoma of cervix.
Thank you.
And I think vaccination is the answer. It will take some time, but I think finally, if we won war against cholera, polio, then HPV is no big deal. As far as the breast cancer is concerned, I think in the Western world, 75 to 80% of the cancers are diagnosed as early breast cancers, and 99% of them are curable if they are still confined to the breast. And therefore, I think the future is very rosy. We just have to, brace up, pull our socks, and try and identify these cancers early.
Can I make?
Thank you. I'll just come back to you again. Now, I'll just sum up what these gentlemen said. First thing, you have to be aware of it. Second thing, make others aware of it too, so that you spread awareness. That makes you more educated, because it always bounces back. They tell you more about something else. Thirdly, early cancer is curable. Most cancers, that is. Advanced cancer is still manageable. I wouldn't say the word curable. I mean, it's a state of mind actually. One doesn't live forever. But for as long as you live, you can live without disease. That's as good as living without the disease. And as rightly pointed out, cancer cervix is like any other communicable, sexually transmitted disease where human papilloma virus has been found to play a role. There are many stains of it. We won't get into the depth of it. There's a question asked, which we'll get back to Dr. Shyam automatically. Familial breast cancer, how do we approach it? Well, I'll just give you a little background. First of all, there's no reason to be scared. It's important to be aware everybody doesn't get it. And one shouldn't get into that syndrome. I won't name the lady where prophylactic mastectomies were done. The idea is to be aware, and it is possible to detect it early if you know that you may get it. Therefore, you are one individual who has got a sibling, first degree relative who's got breast, ovarian or pancreatic cancer occurring at a younger age. You are a candidate, but you don't need a BRCA1, BRCA2 immediately. You may need it in a select group. There are various varieties of it. I'd like to ask Dr. Shyam to throw light on it, and you can add up what you were saying.
Right. So before I answer that question, so no discussion today is complete without discussing the genomics of cancer today.
I was coming to that.
Right.
Exactly.
So you know, so these cancers are developing because of corrupted DNA. So we have the technology now, which is called, say, next generation sequencing, to identify the driver mutations. So which are making these cells rogue and divide and, you know, metastasize and so on. So we, for example, are soon indulging into a next generation sequencing program in breast cancer patients. And cancer is not a sort of stationary disease, it evolves.
Evolves, and therefore you need to have.
So you need to actually chase the cancer, and you need to have you know, studies done on sequential basis on the genomics of various cancers, including breast cancer. So I think we have now drugs to target those driver mutations and control cancer in not only breast cancer, but a variety of cancers like kidney cancer, lung cancer, etc. And that actually is the future of cancer treatment today, which could be judged, you know, by several physicians and people who are into research in the field of cancer.
Fixing your genes.
Absolutely.
I mean, it's not too far away.
Absolutely.
We're looking at nanotechnology, where you'll actually have your genes across the counter, where you'll find this one I don't like, I like the other one.
So personalized treatment.
Yes. Personalized treatment. And there are mismatch repair genes which undergo mutation.
Yes.
They're genes that are supposed to fix any aberration that is happening. By and large, friends, it is not such a gloomy scenario. We should be able to conquer it. But having said that, there is a word of caution. There has to be awareness. You should be at the right place with the right person at the right time. So if you present early to the right person who treats it, and the right tests are done on you rather than you doing it on yourself, and if the right treatment is offered at the right time, the outcome is definitely right, and cancer can be conquered. And especially these two cancers are good news. When Dr. Shyam was mentioning about the evolution of therapy, now we have targeted therapies for breast cancer, especially for, we didn't address that, the first target was the ER receptor by tamoxifen. That was itself a targeted therapy. Now we have Herceptin that will target HER2/neu. So we have a good news coming almost every day in terms of better survival with various therapies that are available. With the technologies we have improved in assessing and following up these patients, and as rightly mentioned, it is about 1 to 2% that contralateral breast can develop cancer in the lifetime of a patient with breast cancer patient on one side. And it is possible to cure it with the patients of breast cancer living 20, 24 years, 25 years, and if they come to you at 50, they've done 75, which isn't too bad actually. By and large, most patients do quite well if detected early. Now, I would like to thank the panelists for contributing to our understanding about these three cancers. I hope you enjoyed it as much as we enjoyed getting it to you. I thoroughly enjoyed it, and I'm sure you enjoyed it too. It is reflected on and by the questions that you asked. It clearly showed that you were interested. So till the next time, thank you very much. Have a great day. Thank you. Thank you very much.
Thank you.
Thanks.